Okay.
So hello and welcome to the Tina's Wish virtual town hall and webinar focused exclusively on COVID-19 today. For those of you that may or may not know, Tina's Wish is a national not-for-profit that funds scientific research for the early detection of ovarian cancer. But like everyone else, the only thing that we can all be thinking about is coronavirus. And we believe and we feel so fortunate that we have incredible connections to our doctors and researchers in the scientific community. And today we're really honored to be able to share that expertise with all of you. So just a few housekeeping things before I turn it over to our doctors. The first piece is that no information today should be construed as personal medical advice. If you're dealing with any kinds of personal medical situations, please contact your doctors immediately. The second thing just to note, I'm sure you've all been on a lot of these Zoom calls already, but all of your phones are on mute except for our speakers. So that if you do have a question, please utilize the chat function and we'll try to get to them at the end of the session. We anticipate that our program will take about 20 to 25 minutes. And then from there, we'll try to answer any questions or topics that may not have been covered to date. We will be recording the session and posting it to our website, and we will share it with all of you that have registered, as well as on our social media platforms. We are using slides, so you may find it helpful to utilize the split screen and the speaker view in order for you to view both the slides and the speakers. So I'm very honored to welcome we hope all three of our very talented researchers to join us today. Dr. Kevin Elias, who is a Tina's Wish funded researcher at Brigham and Women's Hospital in Dana-Farber. He is currently actually serving in the Brigham and Women's ICU ward for corona patients, and we're hopeful that he's still able to join us today. Dr. Marc Goodman from Cedars-Sinai, he's an epidemiologist and serves on the Tina's Wish Scientific Advisory Board. And Dr. Doug Levine, also a Tina's Wish funded researcher and chair of the Tina's Wish Scientific Advisory Board. These are the topics, do not take any notes, that we'll be covering this morning. And as I said, if you have any additional questions, please send them to me and then we will try to answer them after the formal part of the presentation. So Dr. Levine.
Hi, good afternoon to some, good morning to some. Beverly, can you hear me okay?
I can hear you.
If the audio breaks down, just let me know. Welcome. It's nice to see some familiar names and some familiar faces on the line. Just a reminder, as you hear from everybody and we hear from our hospital leadership as we do our internal planning, this is a very fluid situation that continually changes, and that is certainly the truth. And so what we discussed today could change this afternoon. And of course, we are not, none of us are infectious disease experts, in a coronavirus is, but we are medical experts. And one of the goals was to just provide some, mostly reliable information to the extent that it's available. That's what we will try to do today. Are you advancing the slides, Beverly?
Yes.
Okay, next, please. So, yeah, this is a very good question, and we'll get to something on the next slide, but just to put things in a little bit of perspective, as of now, it's estimated there's nearly half a million cases in the world, with just over 22,000 deaths. In the US, we're almost up to 70,000 cases, with just over 1,000 deaths, it looks like. People are recovering from this, and so that's important to keep in mind. And this certainly will go away / get much better in the near to not too distant future. No one knows, of course. We can discuss that if we're so inclined. But to put those numbers in perspective, in the United States, there are 34 million cases of the common flu every year, and there's about 34,000 deaths every year in the United States from the common flu. And every week, during flu season, every week about 400 to 500 people die from the common flu. And so in the United States, this is very serious, and we're all very concerned about this, and it's something we really need to take seriously, and we don't know what the future is going to hold, but just nice to, consider how this compares to the flu, and those are some of the numbers from the common flu called influenza. This coronavirus actually is a virus that's not the same as the common flu. It's actually the same as the common cold. And so coronavirus has caused the common cold, and obviously this is not the common cold, but it's that classification of viruses that cause the common cold. Next slide. So this is kind of a very interesting graph that was published in Nature that really explains why, I'm not sure where that, do you see that box in the middle also, Beverly? Oops, I just lost the slides. This is an interesting slide from Nature that I don't think we're seeing right now. It'll come back shortly, but there's a couple things you think about when you think about these infectious diseases, and I was not an expert on this, before this all happened, but I've since learned, and we'll try to explain it. So one is the case fatality rate. So how dangerous is this to causing deaths? And the common flu, the seasonal flu, we know a lot about that. And the case fatality rate from the seasonal flu is approximately 1/10 of 1%. We're still working on the slides. Is that right, Beverly? Oops, I seem to have lost.
Nope, I'm here. I just had muted myself. Yes, I'm working on getting your slides back.
Okay. Do you want me to share my slide copy?
Sure.
I don't know if I can do that. I don't know which is which. Let me
Just
try
give
this.
me a minute. I'm trying to regain.
Can you see my slides?
Yes, you just need to go up.
Okay.
There you
Yes?
go. Perfect.
Yes? Great.
Yep.
Good. So this is the slide we were on. And basically, the case fatality rates on the left side. So Ebola, of course, we all know is very, very dangerous. And you could see the avian flu, tuberculosis, other sorts of things. And orange, I guess, is coronavirus. And right now, that's showing a case fatality rate of around 3 or 4%. This number also is going to be very fluid. My personal opinion is it's going to be about 1%. Again, not being a board certified epidemiologist, but the reason, as you all know, is we're not really doing testing, and we've actually stopped testing in New York City and New York State for very obvious reasons we also can discuss later. But we certainly know about the sick cases, and so we know who's dying, we know who's getting hospitalized, but we don't know how much coronavirus is in the community. And so that means the denominator is probably going to get much bigger. And the numerator, people who get sick and or die, will probably stay the same. And so that's why my opinion, could be wrong, but my opinion is the case fatality rate is probably going to go down to about 1%. Why is this so serious? It's serious because the chance of dying is about 10 times as much as the common flu. But this other thing called the R0, or it looks like a R0, but it's pronounced R0 because it's British, of course, is the basic reproduction number. What this means is how many, when someone gets infected with the virus, how many other people will it be transmitted to? And so for the common seasonal flu, it's about 1.3 to 1.4%. Meaning everyone who gets the flu gives it to 1 or 1.5 other people. For COVID-19, we think we're in the 2 to 3 range. And so everyone who gets COVID-19 or coronavirus will give it to 2 to 3 more people. So it's about 2 to 3 times more contagious and about 10 times more deadly than the seasonal flu, which again, as I mentioned, is not something, that is not very serious, but that's sort of the relativeness. So it's bad. It's of course very severe to do what we're trying to do about it. But it's, these are sort of the best numbers we have right now. Okay, let's see what's going on here. So this I sort of went over already, a number of cases in the country and deaths. I don't need to talk about that again. And the other couple of differences, which I'll just mention before maybe I'll just switch over here about symptoms and come back to this. And so, because I don't want to forget what I'm thinking here. So the issue with this coronavirus, we think, is that you're contagious before you get symptoms, probably 1 to 2 days before you get symptoms. And with the common flu, you're most contagious about 4 to 5 days after you get symptoms, or 3 to 5 days. So it's tricky that this is in the community and we don't know about it because you don't have symptoms. The most important symptoms are fever, cough, and shortness of breath. If anyone's having trouble breathing, you should go to the emergency room. And that's the only time you should go to the emergency room, is if you have trouble breathing. If you have fever or cough, do not go to the emergency room, but call your doctor. And all of us are doing telemedicine now with virtual visits. About 98% of people get a low-grade fever. That can be 99.5 or higher. Typical fever is usually thought to be 100.4, but you can get a low-grade fever. 98% of people or so get a low-grade fever. About 2/3 of people get a cough. Two new symptoms that aren't on this slide seem to be loss of taste and loss of smell. I have no idea why. Someone says the virus gets in your nose and then you can't smell. I don't really know. But loss of taste and loss of smell seem to be new symptoms of the virus. And at my hospital, we're specifically screening for those symptoms. You also can get regular flu-like symptoms, muscle aches, back aches, what are called myalgias, sort of just like feeling run down. That's the sign of the cold, common cold, the flu, et cetera, and this flu as well. And so symptoms also appear about 2 to 14 days after exposure. Symptoms can also peak 11 days after the infection begins. After symptoms begin, with different common flu, which usually peaks, 4 days. People who do get the sickest actually get most sick after 11 days, and so something to keep an eye on. If you do have typical recommendations, get plenty of rest, get plenty of get some reasonable, fresh air on occasion, but rest fluids and stay warm.
Doug, we just lost you there. Doug, I think your screen just froze. Okay, Dr. Goodman, maybe you should continue since it seems like Doug's screen has frozen.
Hi, good afternoon, everybody. It's morning for me. I'm in Los Angeles, but I know many of you are on the East Coast. And since Doug was moving the slides, I won't be able to. I don't know if Beverly, you have those slides back on yet, or
I'm trying to do it for you right now. Why don't you begin and I will.
Doug has moved to a better place. But as Doug was saying, he was going through some of the symptomatology and washing your hands. I think you all know this. Looks like, is that you, Beverly, or Doug?
It's Beverly. I'm going to get.
Okay.
Okay, there you go.
Yeah, I think many of you have heard all these preventive measures, washing your hands, and of course, staying at home. And I know many of you in the New York metropolitan area are certainly practicing that because of the density of exposure. Can you put it on the next slide? So are there different symptoms for cancer patients? Obviously, people who are undergoing chemotherapy or just out of chemotherapy are going to be a little bit more susceptible to the virus, and they should, of course, be self-isolating to protect themselves. Whether the symptomatology is different or not, I think we don't know because we don't have enough cases. But obviously, for people who are cancer patients, if they're not in remission already, they should practice extra care and certainly not expose themselves to anybody who might have been infectious already. Next slide, Beverly. So I think Doug has already gone through this. What should you do if you have symptoms? Clearly staying at home and staying in touch with your doctor. Doug mentioned telemedicine has been very effective. I work at Cedars-Sinai Hospital here in Beverly Hills, And we're using telemedicine for a lot of things and getting people to stay at home and self-isolate. I will go through a little bit of the emergency warnings, but you can see that if you have difficulty breathing or shortness of breath, you have persistent pain in the chest, or inability to get yourself out of bed, or you're confused more often than you normally are, or you're, you look blue, which indicates that you're not getting enough oxygen, you should clearly get a hold of your doctor and get him or her to tell you what the next step is. Because emergency rooms are so overcrowded right now, the last thing you do is to want to hang around an emergency room with a lot of other people who may also be infectious. So stay in touch with your medical practitioner about that. Next slide, Beverly. So in terms of risk, so obviously risk depends on a lot of characteristics of a virus, how it spreads between people, the severity of the illness. So what your risk of exposure is the immediate risk is still low for most Americans, maybe higher in places like the New York metropolitan area than places like Los Angeles, but we still don't have as dense an infection as they do in Italy. I just talked to friends in Rome who are required now to stay at home. Community spread is very important. I think you've heard about a lot of people going to the beaches. Even Santa Monica out here was closed because a lot of teenagers and young adults were hanging out. Healthcare workers are clearly at elevated risk, and close contact with anybody with COVID-19 will be at elevated risk. So that includes people who are traveling. Your risk of severe illness, we reviewed a little bit. This is more information from China, but it's older adults, because as we grow older, our immunity goes down, particularly men, because we tend to have slightly lower immune response than women do. And of course, people with serious chronic medical conditions like heart disease or diabetes, lung disease in particular, as well as HIV and asthma, can put you at higher risk. I also wanted to say that, there has been some evidence. I think this may be in the next slide, Beverly, but I'm not sure because you still have, yes, it is. So there is some evidence for younger people being hospitalized. We're not sure why that is. About half of ICU admissions and deaths have been reported in those 65 and older, but there are some young adults who seem to be susceptible. So aside from the things that I've already mentioned, clearly young people who are being exposed to others are going to be at greater risk. But the jury is still out on whether there's any differences. The likelihood is it has to do with exposure rather than susceptibility to the illness. We're also concerned, I think, about pregnancy and pregnant women. They should obviously take better precautions, but we don't really have very much evidence for differences here. We don't know whether COVID-19 can be passed from a pregnant woman to the fetus, so we're trying to be careful about that. Can you have the next slide, Beverly? I don't think that was it. Yes, there. So everybody's heard about flattening the curve. I'm sure you've seen this in many newspapers. It's an epidemiological term that refers to protective practices, basically to slow the virus down so that hospitals have rooms and we have supplies for our doctors and all of the patients. If you have too many young people who become ill, then you can overwhelm the system and have a shortage of hospital beds and doctors. And we clearly don't have enough beds. I know the Javits Center has opened up. We're going to open up a hospital here. It's on a boat. But if there's a large number of people who arrive at the same time in the hospital, there's also possibility for infection. And then finally, if we can flatten the curve, then we can weight a lot of the trials that are going on to see if we can do something better to treat the virus. Next slide, please. So what should you be doing now? I bet you everybody is doing the right thing. We kind of wanted to reiterate what the differences are. So social distancing obviously is what we should all be doing. In the United States, we're using 6 feet. They're using things like 1.5 meters in Europe. You know, avoiding mass gatherings and working from home if possible, like it looks like many of us are doing, is a prudent thing to do. In terms of self-quarantining, you know, to separate and restrict the movement of people who are well, like hopefully all of us are, is also the smart thing to do. So people who have been exposed and don't know it should clearly, you know, be self-quarantined so they can't expose anybody else. And then finally, self-isolation. I don't know if you saw the article in the New York Times Magazine section a day or two ago, but it's a term, a healthcare term that we use to mean people should stay away from everybody else because they're contagious. Completely separate sleeping, living, eating, bathroom facilities are required. And you can do that at home or a hospital or a care facility. We also have special personal protective equipment in many instances, although, as you know, those are in short supply. Next slide, please. So what about testing? Well, you need to call your doctor. This is, again, what Doug talked about, because those symptoms may appear as much as 2 or 14 days after exposure based on the incubation period of the MERS virus, which is what we've been relying on. Doug already reviewed common symptoms like a fever, a cough, or shortness of breath. If you develop emergency warning signs, again, like trouble breathing, pressure in the chest, or confusion, or bluish lips in the face, call your medical provider and ask him or her what to do. So in terms of home testing kits, I know information has been out about that, but right now there are no Food and Drug Administration authorized tests that are available for purchase for testing yourself at home. So if you see these things, please avoid them, probably report them as well. We see, and certainly FDA does see, public health value in expanding availability of testing. But right now, you know, I just heard on the news, Fauci was on again saying that this has been revved up. Many of the pathologists I know who run microbiology clinics have already created their own tests. For example, my colleague at University of California up at Davis has done. But hopefully we will have tests, and those will get out to everybody, enough tests, and those will get out to everybody really quickly. The final thing I wanted to say, there is a new investigational vaccine that's being developed by Moderna Therapeutics, and they're running clinical trials up at Kaiser in Washington Health Research Institute. And hopefully they and other people will come up with a vaccine sometime. But these things take a really, really long time. I doubt a vaccine will be available, a prophylactic vaccine will be available anytime soon, probably in the next 12 or 18 months. And that would probably be true also for a therapeutic vaccine. So again, we are searching for other therapies, and as Fauci has told us, we still don't know the results for those, for example, chloroquine, but all of us are very hopeful about that. Next slide, please. I think I covered these, and our hope is that you know, drugs will be available. Many of these drugs are being tested and screened by UCSF, Hopkins, and Harvard, and hopefully in the next few months or so, we'll have something available to everybody. Next slide, please. I don't know if Doug is back on, but maybe Doug would be able to talk about cancer patients.
Sure. Can you hear me?
Yes.
Yep.
Yeah, sorry about that. So, you know, cancer patients are just another high-risk population. Obviously, you know, like Mark was saying, you should, you know, take the usual precautions. At our cancer center, when cancer patients come in, we do see a limited number of people who still need to be seen. Patients and providers are wearing masks. And just a comment about masks, masks are thought to prevent the transmission to other people. So we wear masks in case we're exposed but still healthy. It's not known that masks prevent you from getting the virus. Masks can help prevent you from touching your face because you have a mask there, so that could be a benefit of a mask, but masks are not necessarily known to prevent you from getting it, so people do want to take precautions. We do think that our healthcare facilities, at least at NYU, I can say our healthcare facility, we think is actually safer than the grocery store because we're doing so many things to screen people. Everyone's getting their temperature taken before they board any elevators. And so I do think in New York City, for example, the hospitals where people would have to come, or the outpatient offices only as necessary and appropriate, are probably just as safe, if not safer, than the grocery store or some other place you might still have to go to. So we're not treating people who are known to have COVID. We're waiting 2 weeks until, so anyone symptomatic, of course, we're not treating. We want to treat anyone who's sick anyway with chemotherapy. And now, there's no known answer, but our practice currently is that we're not treating people for at least 2 weeks after symptoms subside. If they need chemotherapy, we may be waiting until 3 weeks because we want to make sure all the risk of reactivation of an infection has gone away. And just one more quick thing I just wanted to mention before I forgot. We have a site at NYU for making donations of goods such as masks or other sorts of things. And this has to be done through official channels for a couple of reasons. One, we often hear of, we've heard of cases where people say, oh, I have some masks, do you need them? And they want you to pay for them, which is maybe okay. Some concerns for price increases. But also some products that come from overseas have not been approved by NIOSH, which is the Occupational Health and Safety Board. So products such as masks that haven't been tested may not provide the same protection. So we can't just take masks sort of off the street. They have to go through our receiving unit to make sure that that they meet the standards. But if anyone knows of donations, you know, my hospital right now has enough supplies. Some hospitals are not so fortunate, but we're all conserving. We used to wear masks throw them away after every patient. We're now keeping them for the week. And Kevin, who I see has joined us, will probably comment more on what they're doing up in Boston. But yeah, that's pretty much the cancer patients are like any other high-risk population. We just want to be, you know, extra careful and extra safe.
Okay, thank you, Doug. So now we're going to welcome Dr. Elias, who we know has just spent the past 72 hours in the ICU ward for coronavirus patients up at Brigham and Women's. So we really thank you both for what you're doing for the patients and for giving us your time today.
You're very welcome. Can you hear me, Beverly?
We can. Thank you, Kevin.
Okay,
Dr.
great.
Elias.
Yeah, you're sort of catching me on the break between shifts here. So what we're seeing here, we've set up dedicated intensive care units for patients who are either suspected to have coronavirus or known to have coronavirus. Just to reiterate the point about staying home unless you really need to come to the hospital, what happens right now is if you come to the hospital and essentially you have a fever or a cough or any symptom which could be coronavirus related, you will be, and you have to be admitted to the hospital. We're sort of cohorting those patients into one whole separate building of the hospital. And then they're called PUIs, or persons under investigation. One of the problems we're finding with the COVID-19 test is that it's not a perfect test, and it only picks up between 50 and 70% of cases. So, again, as far as why we don't want to test people who are relatively well out in the community, if you are relatively well and at home and you get a negative test, that may or may not actually be accurate. And so someone shouldn't think that they are totally fine. If people are having symptoms, even if they have a negative test, they should still be self-quarantining or even self-isolating if recommended to do so. At the hospital, in order to declare someone truly negative from the coronavirus, we're requiring 2 tests, and right now it's 24 hours apart. I don't know if in New York they're doing something similar, but now within the hospital, if you are in the hospital and also requiring intensive care, we've set up separate intensive care wards for patients that are either known to be COVID positive or possibly COVID positive. And that's where I've been working. So I'm seeing people who are critically ill, mostly needing to go on a ventilator, and either known to have or suspected to have COVID. But again, it's, as you can imagine, when we have someone who is critically ill, needing to be in an intensive care ward, for instance, they're in septic shock, if we figure out that they're COVID negative, then we're moving them out of the COVID-19 ICU and into a regular intensive care unit. So we have regular intensive care units in a different part of the hospital. We're trying to really conserve the beds for the COVID-19 patients, the ones who are both critically ill and requiring ICU level care. But what is something we're learning, which had not come out from the experience in China, is in China they had reported that the incidence of co-infection was very low, meaning the incidence of people who say had coronavirus as well as say a bacterial pneumonia or another type of viral pneumonia was low. In the US at least, or at least in our experience, that's not true. We are seeing at least 20 to 25% of patients actually are co-infected. So if someone has, say, gone to their doctor and the doctor said, oh, you just have strep throat, therefore you couldn't have coronavirus, that's not true. We are certainly seeing that co-infections do happen. And a number of the patients who do get severely ill with coronavirus are getting secondary infections. So when we see this commonly with influenza as well, people get viral pneumonia, and then subsequent to that, they get a bacterial pneumonia. We are seeing that as well with coronavirus. People will get a coronavirus pneumonia and then later on get bacterial pneumonia. As far as cancer patients specifically, so because of our affiliation with Dana-Farber, a large percentage of our patients are cancer patients. We certainly are seeing them being at higher risk. It seems to be patients whose immune systems are actively compromised. We're not seeing a lot of people who say were cancer survivors a decade ago or years ago and are not currently thought to be immunosuppressed, having a higher risk. What we're seeing more of are patients who are, say, have had an organ transplant and are actively immunosuppressed, or they've had a bone marrow transplant and are actively immunosuppressed. They have hematologic malignancies like leukemia or lymphoma or multiple myeloma, and so their immune systems don't work as well. Again, I'm seeing the sliver of patients that are that critically ill slice, but those groups of patients are definitely overrepresented within that set of patients. The other thing we're seeing as far as what patients are telling us when they come in is there's quite a delay in likely exposure to onset of symptoms. So the whole idea of quarantining people for 14 days certainly makes sense. We definitely are seeing that patients are often reporting exposures that seem to have been a week or so ago. They are likely infectious for several days before the onset of symptoms. The other thing to note is that many of the patients don't actually have cough or shortness of breath at initial presentation. Many of them will either have just a low-grade fever for a few days first. So if people say, like, well, it's just a little bit of a fever, I don't have any cough or shortness of breath, that certainly does not exclude coronavirus. And the converse is also true. So when we talk about a very high percentage of fever and shortness of breath, that's sort of eventually. but those symptoms don't necessarily have to come on at the same time. So I think, Beverly, I can, oh, and the other thing about the therapeutics, so there are 4 drugs that are being actively investigated right now. I will say they're for various degrees of severity of coronavirus. The 4 drugs that have been looked at, one of them is an anti-HIV drug. At least in an initial series from China, it was a relatively small study, but it was a randomized trial, about 60 patients that did not show any benefit. But they are conducting larger studies on the anti-HIV drug. There's also 2 drugs for patients who are much more severely ill. Remdesivir, which is antiviral made by Gilead, which is, we have several patients that are on that clinical trial right now. We're hopeful we'll start to see some activity for that, but that's really being used for patients who are at ICU level care. Same thing as far as a drug which is targeting what's called the cytokine storm effect of coronavirus, which is sort of this overwhelming revved up immune system response where people get very sick. That's also being tested in again, the critically ill patients. And then the one that people probably heard about on the news is hydroxychloroquine or Plaquenil. So again, this is an anti-malarial drug, which is also used for treating lupus and rheumatoid arthritis. We are actively studying that as well. I know that there was a lot of hope around that, and that's sort of based on the idea that hydroxychloroquine shows activity against coronavirus and both this coronavirus and other coronaviruses, at least in laboratory assays. I guess the 2 words of caution I would give about hydroxychloroquine are that it has been tested in active clinical trials for a number of years in many different viral diseases and has never been shown to have any antiviral activity for any condition. And in fact, when it was used for things like in trials for Ebola or swine flu, it actually made it worse in some cases. The other thing about hydroxychloroquine is, as I said, it is a drug that's used for Plaquenil, as Plaquenil for rheumatoid arthritis and lupus patients. And there's a lot of concern about there being severe drug shortages of it for those patients, many of whom are very dependent on it. And so we are, again, only using hydroxychloroquine for hospitalized patients, not for patients who, might just be feeling unwell at home. And even in the hospitalized patients, we're trying to use it for the ones who are severely ill but don't fall into clinical trial eligibility criteria for the other drugs.
Okay. All right. Thank you so much, Dr. Elias. Right now, we're going to switch to some of the questions that people sent in to us ahead of time, and there have been a lot more that have come through on the group chat. So we'll start with the ones that are on the screen. Dr. Elias, I know you're not on video, so I'll quickly read the question, and then I'll just allow any of the doctors to please reply. Mark, I'm just unmuting you as we speak. So the first question is about transmission. Is the virus airborne? Could I catch it by working in my yard? How long can the virus remain on a surface? What should be a protocol for delivered newspapers to my house, delivery of food items, prepackaged items that I might bring home from the grocery store?
Don't all jump at once. The virus is transmitted mostly through respiratory droplets, except in rare hospital situations where it can be what's called aerosolized. I would think you cannot catch it working in your yard unless you're working next to someone who's coughing on you. This is the 6-foot thing that's been recommended. There was a pretty good study that came out about last week talking about surfaces. So things like cardboard and plastic, it can stay on those surfaces. Copper actually is a surface it can stay on the least. Stainless steel, it can stay on those surfaces. It's been detected on some of those surfaces up to 72 hours, but not after 72 hours. But at 72 hours, the amount of virus, or what's called the viral titer, is very low. And so, we all have some ability to fight off things. And so at 72 hours is very low. The half-life of the virus is between 1 and 7 hours on these various surfaces. And so, if someone, so people ask, well, was someone coughed and I walked past that space, the next day or a little bit later? It can stay in what are called aerosolized situations, but that's when it's created artificially in a laboratory. So, in the air that you're walking around, when you cough, things don't stay in that air for very long. And so unless you, were right behind somebody, which certainly could be a risk, it just, working in the yard, for example, there's not going to be virus hanging around just in the air. As far as packages and delivery items, I don't know. The virus title will be less. I do get the New York Times and I pick it up and read it, but maybe I should wash my hands afterwards. But yeah, I don't know about these items. I can tell you that they don't stay for a long time in the packaged items. But you don't know if someone's gone in front of you and touched it, so to speak. You can transmit these things. Obviously, you touch your face, you touch something else. One thing we haven't mentioned yet, and just to sort of put it a little in perspective, at this point, I would just assume that everyone has coronavirus. As Kevin said, there's false negative tests. People aren't symptomatic. People can be pre-symptomatic. The way we are operating is just you assume everyone has coronavirus, which is why we're all staying, in our homes or in limited contact with each other.
Yeah, just to echo what Doug was saying there. Yes, assume that everyone has it is the safest thing to do. Sort of what we call in the hospital setting, universal precautions is the best way to go. We are in general recommending people use prepackaged items rather than, say, unpackaged things. So in the hospital cafeterias right now, where everything is coming as individually prepackaged so that people can't pick up things themselves. The studies about the virus and how long it stays on surfaces, just to emphasize, that's how long the virus is detectable. Those studies did not look at infectivity. So for instance, as Doug was saying, we don't know if because there's a small amount of virus detectable, is that virus actually still infectious at that point? Probably not, because you usually need a minimum viral titer to actually be infectious. And the sensitivity of the test that we're using to detect in a laboratory setting is very, very sensitive. So just because virus particle is there doesn't mean it actually is still active.
Perfect, thank you. I'm going to skip to one other question on here about reinfection. If you recover from coronavirus, do you develop an immunity to prevent a recurrence? Is there any data to support the idea that those who have had COVID-19 will be immune to contracting the virus again? And for how long after you have the virus can you still be contagious?
So the answer to these is we don't know, is the short answer. We do see that people who have had coronavirus will develop some antibodies to coronavirus, but the presence of antibodies does not necessarily equate to immunity. So for instance, if you test people for antibodies to other types of coronaviruses, so the 4 coronaviruses which cause the common cold, people will have antibodies to them. However, most of those antibodies are not protective. We all know that you can continue to get the common cold. In fact, the seasonal colds that we all get, we pretty much all get the same 4 coronaviruses over and over and over again. And so there might be partial immunity to them such that within the same cold season, you might not get that particular coronavirus strain again. But at least with other coronaviruses, that immunity does seem to wane over time. That's one reason why getting a vaccine against the common cold is really not proven successful. But with COVID-19 in particular, we don't know yet. We're hoping that there will be at least some lasting partial immunity so that if you get COVID-19 again in the future, it will be a less severe infection, or that partial immunity combined with, maybe by a year or so from now, some vaccine might give us at least annual protection. Just like you need a flu shot annually, perhaps that will be true of COVID-19 as well. There might be some sort of regular vaccination to prevent severe infections.
also add, though, that the presumption in many places, for example, the UK for a long time, was that people would be at least somewhat immune, which is why the concept of herd immunity has been talked about, which is when you have a large group of people who've been exposed and are immune, that would protect the people who have not been exposed already. So there's a lot of assumptions going around that haven't, as Kevin pointed out, haven't really been proved.
Okay, thank you. We did have a question about cancer survivors who are no longer under treatment considered to be at higher risk. Maybe Doug or Kevin, if you wouldn't mind just addressing that quickly once again, because I know that there are a lot of concerns about that, particularly we have cancer patients on the line.
Yeah, it's a good question. As we mentioned, cancer patients are in a vulnerable population, and I guess it's obvious if you're on treatment that's a concern, but there is one study that came out maybe 2 weeks ago in Lancet that's pretty small from China. There were about 18 cancer patients more or less in there. And it did show that both cancer patients and cancer survivors were at increased risk for more serious symptoms. We could hypothesize what the reasons were. Some of those patients did have lung cancer, some didn't. If you've been exposed to chemotherapy, it does, have some effect on your bone marrow and your immune system in the future, which would not really necessarily make such a big deal or be a big concern under sort of regular circumstances. But the data with the very small sample data would suggest that cancer survivors are at somewhat of an increased risk.
Yeah, just echoing what Doug was saying, with the reports that have come from China, they unfortunately haven't been overly granular. So in other words, they've said this many percentage of people had cancer, really without subdividing what type of cancer they had or where they were in treatment. And so we are extrapolating a lot from that. And again, the types of cancer that they tend to see in China, where rates of smoking are much higher than in the United States, you're presuming a lot of lung cancer patients, but again, it's a lot of presumption. At least I can just tell you anecdotally from what I'm seeing, I'm not seeing a lot of people who have a remote history of cancer. It's really people who have ongoing immune system impairment, at least the ones who are getting critically ill.
Okay, great, thank you. I'm going to ask one more specific question to cancer patients, and we'll switch back to some more general questions. Could you talk a little bit about the trade-off of post-treatment surveillance appointments with the risks of going into a hospital during the COVID-19 outbreak? Example, blood work and CT scans.
Yeah, this is pretty straightforward. We're trying to keep everyone out of the hospital. So we're doing a lot of telemedicine. Routine visits are completely canceled. We're talking to people by phone as needed. We're rescheduling appointments for 3 months out. We're having people go to local laboratories just because we don't want people coming in the hospital, both for everyone's safety, for the hospital staff, for the other patients who are in the hospital immunosuppressed, and for the person coming in. And so this is, obviously a form of social distancing in the healthcare system. I was in clinic on Tuesday. I saw 2 people who were getting chemotherapy who had to be seen. You cannot get chemotherapy at home. There's many things that go into administering chemotherapy, and you have to be in a proper place, which is not the hospital, but the office. And the other people I'm seeing are people with urgent, surgical issues that either need to be evaluated and or have surgery, although I'm also doing some pre-surgical evaluations by telemedicine. So we're definitely trying to keep anyone away who does not actually need to be examined. We're not wearing white coats anymore. We're not wearing ties like they don't do in England for a long time. And we're also doing a lot of preoperative stuff for telemedicine. We're not even examining people anymore unless we really have to, because we want to keep our distance from all people as well, because we assume everyone has coronavirus.
Okay, so I think that also answers then maybe one of the questions online. Is there a way to arrange for chemotherapy to be delivered at home rather than in a hospital setting?
Actually, not for intravenous chemotherapy. For pills, it's a good question. Some chemotherapy is delivered by pills, and those often could be delivered potentially at home. I haven't done that myself, so I'm not sure of the logistics, but from a medical perspective, you probably could do that.
Okay, perfect. I'm sure this might be the million-dollar question. I don't know if you all have any greater insights, but how long do you think COVID-19 will be present in the United States? And when will people begin to feel safe again?
It's not going to be done by Easter, I can tell you that.
Would you like to elaborate?
I think the question. Yeah, I think the question is really, are we? And again, this is just what we just don't know. What's the length of time in which we're going to be really at risk of overwhelming our capacity in the system, versus what's the, how long do we expect it to be circulating out in the community? And this really gets to the whole flattening the curve idea. I think, if we are able to flatten the curve, we do expect it to be circulating around for the next 12 to 18 months. I think the question is, at what point is it, has everyone been exposed to it sufficiently, and that we're able to be relatively well assured that we're not going to overwhelm the hospitals? That's the big issue. So I think we're still looking at least probably a couple months on that. Looking at the experience from China and Italy, where, in China, we know where they peaked their cases and started to come down. Italy, it's actually unclear whether they've even reached a plateau yet. Certainly in Spain, they have not. Certainly here in the US, we're still on the upward tick as far as the number of cases and the number of severe cases. So I think the next couple weeks will be a little bit more telling. And it may vary depending on where you are in the country. Certainly New York, which is seeing the biggest surge in cases right now, may peak as far as levels of infections before other parts of the country, which will probably be hit in later on as the spring and the summer progress.
Yeah, I would agree with that. I mean, a lot will also depend upon in and out migration from the community. So if New York manages to reduce infection, but a lot of people move in who are infected, that could, create another round. I think one thing that countries like Singapore have been able to do is immediately deal, once they find that somebody's been exposed and test positive, is to identify people with whom they had had contact and to quarantine them. And that's how levels have remained low there. But we don't have enough testing kits quite yet to be able to do that, nor protection for people who are doing the testing itself. So we're a little bit behind other places like Singapore that have had a lot more radical ways of approaching confining people.
Thank you. I've had a few questions about symptoms. Does a sore throat count as a symptom? And then the next question was, you mentioned about the smell and the taste, losing those sensations or those features. Do those come back over time when one recovers?
So sore throat can be a symptom. The other thing is we're seeing about 10% of patients have GI symptoms, so nausea and diarrhea. So that came out in the reports from China, that as they started to see more cases, there were some patients who presented to the hospital actually with abdominal pain, nausea, and diarrhea, and then subsequently were found to have coronavirus. But sore throat can certainly be a symptom. And so people who have symptoms that might otherwise be consistent with, say, strep throat, that could be coronavirus still. Again, it would be the same situation where only if you had symptoms that were severe shortness of breath, or that would need you to come to a hospital, would we want you to actually come in and get tested for that. The taste and smell, I don't know what to say. We don't really know whether it's going to come back or not. We don't have enough patients that we've been able to ask and say. I don't know if Doug or has any insight into that, but I haven't heard as far as it being a lasting problem for patients.
I mean, I do know that turnover of neurons in your nose, which help you to smell, turn over about every 4 to 6 weeks. There are other things, for example, people who lose a large amount of weight, for example, who've had bariatric surgery, do have changes in taste and smell. And I know some types of dementia are also associated initially with loss of smell. So it's a very complicated question. So I think we don't know, but the assumption will be with turnover that we will probably get back our sense of taste and smell, that it would only be temporary, but I don't think we know that yet.
And are people who are vaping at a higher risk as their lungs might already be damaged?
Yes.
Yes.
I think that this is definitely one of the confounders we're seeing as far as young people. You know, how many of them are either vaping or exposed to being vaping, and is that why we're seeing maybe more hospitalizations for young people than we would have expected? That there has been some concern, and there's definitely been a higher risk of severe infections in people who vape.
Okay, thank you. I have one last question, so if anyone has anything additional, otherwise we will try to finish within the hour. The question was asked, how is this virus, this pandemic, affecting cancer research, both on the bench, translational, and clinical trials? Because obviously, once we get through this, there will be other concerns and other medical concerns out there, and how will we be sure that we're still providing the best medical care?
This has had, like, I can tell you for my studies, it's had a huge impact. So any studies of mine that are observational or don't involve medications that patients need were halted a few weeks ago. In fact, UCSF, I think, stopped about 3 weeks ago. So all of our really large studies were halted quite early on. We only have a few trials that are ongoing where the patients who are on the medication might be in need, and they have usual care visits, so we can piggyback our research visits on those. But everything has been halted. All of our meetings have been stopped, and a lot of our NIH reviews have been paused. So it's had an incredible impact on the research, at least that I'm doing. I'll let Doug say what's going on with his stuff.
Yeah, I mean, most laboratories, at least in New York and Boston, have been completely closed. We're almost completely closed. We have a little bit of animal work that we're just maintaining because they're longer term experiments. We only have one person coming into the lab twice a week for about an hour. So all our clinical trials are all on hold except for people who are already on treatment-related clinical trials. So it will, put a damper on things. We have to stop and then start up again. So I'm just thinking roughly this is going to be a 3 to 6 month type of delay. We'll obviously need a lot of support from everybody on the phone when we do get back to operations, particularly for early detection research for ovarian cancer. But yeah, it is putting things on hold, but it will continue. I got to run, Beverly, to something else, but I just want to say to everyone on the phone, just assume that everyone has coronavirus. Don't come to the hospital unless you really are short of breath. You do not need to be tested. If you think you might have coronavirus, you probably do. We are actually running short on the swabs for testing. We actually have the test kits. We have the viral media that we transport the test in, but we're running short on swabs and have to preserve those for people who need them. So stay home. All the advice you're hearing from everyone besides the president is very good advice. Stay home, wash your hands, don't come to the hospital, and just assume if you're not feeling well and everyone else that you have coronavirus, and this will pass. We'll get over it. Good luck to everyone. It's nice to see Mark and Beverly and Kevin. Good luck to you. And thanks, and have a good afternoon.
Hey, I just want to thank all three of our doctors for giving so generously of their time and their expertise to us. We will be sending out the recording, so you're welcome to share it with others or to re-listen to it. If you do still have any specific questions, please feel free to email us. We have some additional resources that we'll be sending out, which will be hyperlinked as well. And we just want to continue to wish everyone continued good health. And I hope we found today's session helpful, and we look forward to staying in touch.